If you haven't heard of preeclampsia or had it, you probably know someone who has. Like my sister had preeclampsia.
Okay.
And that in and of itself makes me at a higher risk of getting it.
Wow.
So there are all these little things that people don't even know put them at risk. So when they go to their provider and they're pregnant and they're enjoying the excitement of having their first baby, first pregnancy puts you at risk of preeclampsia.
Really?
Yep. So there are all these little risk factors that are there that if someone doesn't tell us, we wouldn't know.
Hello and welcome back to another episode of the Birth Lounge podcast. Have you heard about my completely free class that teaches you 6 evidence-based ways to avoid a C-section and reduce your tearing in labor by up to 50%? And remember, I mentioned it was completely free. This class is going to teach you how to advocate for your preferences in the birth room so that you can have a birth that's filled with joy and not birth trauma. Advocating for yourself starts with being empowered with the right information so that you can ask the right questions and confidently make decisions during labor based on what feels good to you and your baby. But here's the thing. The U.S. has one of the highest C-section rates in the world, and it is ever climbing year after year. And it's not because the system is broken, albeit it is, but it's really because women don't have the tools to navigate that broken system. We may not be able to change the system before you have your baby, but what we can do is change how you operate within that system. Change the conversations that you're having with your providers. Change the places that you are getting your information to help you have informed conversation with your doctor before you have your baby. I want to teach you how to do that. We know the reasons that our C-section rates are climbing. We know the reasons that inductions happen so often, and we know the reasons that babies end up in the NICU. I want to help you avoid all of that so that you can have a birth that you love. You can find my free class at thebirthlounge.com/C-section so that you can learn 6 evidence-based ways to avoid a C-section and reduce your tearing in labor. Again, that is thebirthlounge.com/C-section. See you there. Bye. Guess what, you guys? If you are hearing this, then that means that baby Saggy is here. And I am officially a mom. A mom on the outside. My baby is here. And I'm on mat leave, and I am enjoying newborn snuggles and probably the same postpartum struggles that everyone else faces. And I'm just wrapped in that newborn bubble. So one of the things that we did while I was preparing for mat leave is we looked at 2 things: our most popular podcast episodes and our most requested podcast episodes. And so then we took those episodes and we decided to re-air them while I am on maternity leave to help you continue to get the best, most up-to-date, and most requested information and education while I am away. So today's episode is a re-air. You will be able to find today's guest bio in the show notes along with any of the links, and we will note what episode number the original episode was in the show notes as well. So I hope that you enjoy today's re-air, and please know that you guys are absolutely on my mind. I'm hanging out over on Instagram, so if you want a real play-by-play on our newborn bubble, head over there and say hi. Otherwise, enjoy today's episode. Hello, and welcome back to another episode of the Birth Lounge podcast. All right, you guys, we are officially in the month of May, which is Preeclampsia Awareness Month. So I thought, well, obviously, we have to talk about pre-E. Do you know what preeclampsia is? Are you aware that it can happen to anybody? Typically, when we think about preeclampsia, we're thinking about someone who has passed 20 weeks, so you're over that halfway mark. You may or may not have had high blood pressures in the past, but now, after 20 weeks, you're starting to have high blood pressure readings when you go to your prenatal appointments. You may or may not have proteins in your urine. You may or may not have a headache. A lot of people experience swelling, but not everyone. Today, we're going to be talking to my friend, Dr. Lexi Hill, who is an OBGYN and a high-risk MFM, maternal-fetal medicine physician, and we're going to be talking about preeclampsia. On YouTube, it's a way more casual setting than I typically am in. Dr. Lexi and I are actually friends, and so we were hanging out and we decided to record this podcast so that you could have evidence-based information about preeclampsia so that you can be familiar with what the signs and symptoms are and know the questions to be asking in your prenatals and know how to bring this topic up with your provider if you think you might have preeclampsia. Preeclampsia is a complication in pregnancy, and it can be very dangerous if it goes undiagnosed and untreated. So the best thing that we can do is know what the signs and symptoms are, and then again, know what treatments are probably going to be offered to you so that you can stay in control of the decisions made and decide what treatment is best for you. Okay, I do want to tell you a little bit about Dr. Lexi before we dive into the episode. Lexi has a degree in nutritional sciences, and she went to med school at Texas A&M and then residency in Arizona, and then she returned to Texas for her MFM fellowship at the University of Texas Medical Branch and is now licensed in over 20 states. She's so rad because she's an OBGYN that really gets it. Autonomy, consent, informed decision-making, like really letting her patients be the leaders of the conversation and the decisions in their pregnancy and their birth space. She really gets it. Oh, and she also has a podcast, The Dr. Lexi Show, and I was honored to be a guest on episode 17, where we actually discussed the dynamics of doulas in the hospital system. Such a good episode, one of my favorite podcasts I have ever been on to date. So, all right, you guys, I'm very excited to let you in on this conversation between Dr. Lexi and I. So, without further ado, here's Dr. Lexi and I talking about everything you need to know about preeclampsia. Dr. Lexi, welcome to the show.
Thank you for having me.
I'm so excited to have you on the show, and I'm even more excited to be in person.
Yeah.
I have not recorded a podcast in person with anyone ever before, so I'm honored to have you be my first.
Thank you. This is exciting.
This is very exciting. I think this is a conversation that a lot of people probably are not prepared to have because it's not something that we often think about when we get pregnant. Preeclampsia is something that is usually kind of a shock. I think it comes as like a, oh shit moment, like, oh my God, I have this diagnosis.
Mm-hmm.
Now what? And so I'm hoping that at the end of this episode, the people who are thinking, oh shit, now what, can walk away and say, okay, I understand what's going on in my body. I understand what my options are.
Yeah.
And I kind of feel in control of the decisions that I'm about to have to make and how this might impact my pregnancy.
Yeah. And the fact that in our world, I guess you could say, the shock for it, it's so common in my world that I really want to educate people on the front side.
Yeah.
Because it's one of those things where if you haven't heard of preeclampsia or had it, you probably know someone who has. Like my sister had preeclampsia.
Okay.
And that in and of itself makes me at a higher risk of getting it.
Wow.
So there are all these little things that people don't even know put them at risk. So when they go to their provider and they're pregnant and they're enjoying the excitement of having their first baby, first pregnancy puts you at risk of preeclampsia.
Really?
Yep. So there are all these little risk factors that are there that if someone doesn't tell us, we wouldn't know. And so there's this great resource, preeclampsia.org, and it's the Preeclampsia Foundation. And they have these wonderful videos and really break it down. But I also have this kind of sheet that people can go and download that kind of helps them to understand, am I someone that's at a high enough risk for preeclampsia? Cool. So it's a disease that I am jazzed to talk about because it's much more common than I think we're aware of.
Yeah, I think so as well. I know that as a doula, nobody expects to have preeclampsia, but we see it often. And I know that it can be very scary. So before we talk about the risk, what is preeclampsia? Can you tell us? And I want you to nerd out. I want you to really tell us kind of like what is going on in our body when we develop preeclampsia.
Yeah. I like to start with the definition first because it just helps. So eclampsia actually means thunderclap.
Okay.
And then pre obviously means before. So it's before the thunderclap. And thunderclap here is seizure. So eclampsia is a seizure, right? We say you've had an eclamptic seizure or you have eclampsia. It means you had a seizure due to preeclampsia. So they actually found out the way we came about calling it preeclampsia was women were having these seizures. And then they were finding out later, oh, these women who had seizures, they had protein in their urine and they had high blood pressure. So then they started to say, wow, maybe we could prevent this because in individuals who have protein in their urine and high blood pressure, they could then go on to have eclampsia. So that's where preeclampsia comes from.
Wow.
So then that takes us backwards into the definition of high blood pressure and protein in the urine. Now, they changed that also. So that's always been the medical students like preeclampsia is high blood pressure and protein in the urine.
Okay.
But in Australia and parts of Europe, they were like, do you really have to have the protein in the urine to meet the definition or the criteria to say you have preeclampsia?
That was one of my questions.
And the answer now is no.
Wow.
So it used to be that. And we used to have all these different criteria. And around 2015-ish is when it all kind of started changing. And so it takes people time to realize change and implement those new definitions. Too long sometimes, right? So it is when people get high blood pressure. This is like definition wise, right? High blood pressure in a pregnancy after 20 weeks of the gestation. That high blood pressure needs to be with one other thing, either protein in the urine or a lab or physical exam finding that's of concern.
Like what?
Yeah. Creatinine, which is like checking your kidney function.
Okay.
Your creatinine starts to rise, showing your kidneys don't function as well. Or liver function. Your liver functions, we call those the AST, ALT. Those go up. That's another one. Your platelets go down. So those are the main three labs we look at. Physical exam findings, headaches that aren't explained by something else. So if you're someone who has a history of migraines and you're just getting a migraine and it's the same, that might not be a typical preeclampsia headache. Preeclampsia headaches are typically behind the eyes, not always. You can have visual changes, blurred, weird vision, almost feels like you're going blind, spotty blindness. You can have right upper quadrant pain because that liver, that's actually caused from an expansion of the liver and it's pushing on this thing called Gleason's capsule.
Wow.
That's a great med school test like question there. But that's where it comes from. And so one of the risks when people get bad preeclampsia, this is bad preeclampsia. Their liver could actually like rupture.
Wow.
That's the bad end, right? So those are some of the findings. Also, you can get fluid on your lungs.
Okay.
So those are, again, the high blood pressure accompanied with either protein in the urine or one of those lab or physical exam findings.
And for the labs, it's a blood draw.
Correct.
Got it. So we're drawing your blood and then looking at that.
Yeah. And for the urine, it's very interesting. The gold standard is a 24-hour urine collection. So you pee in a jug for 24 hours, turn it in, and then they see how much protein is in your urine in a full day. Recently, we started doing protein to creatinine ratios, where you check this protein to creatinine ratio and get a lab. The reason we don't use that all the time is because we eat during the day and our protein levels in the pee might be high and low. Exactly. So you can do it. It's a quick and dirty way to do it. You can also do urinalysis where you just do a quick dip. That's not as good, but in a quick situation, if you dip it and you've got 3+ protein, you actually can count that for helping with the diagnosis of preeclampsia.
So if a patient did the quick dip and they wanted to ask for a 24-hour kind of analysis, is that something that would be possible? Could they then request and say, I don't want to have this diagnosis right now. I would rather have a 24-hour look at my urine and see what comes of that?
You can request it for sure. It may delay the diagnosis, which could be concerning if the blood pressures were high enough where it was preeclampsia with severe features, meaning there's certain criteria that make it more dangerous for the mom and the baby.
Sure.
The other thing with a 24-hour urine collection is you have to bring it back. So if you leave with the jug, you got to take it back and know where to bring it back. And the third thing is, if that dip of the urine is so high and you're at a certain gestational age and you have certain symptoms, it may be dangerous to delay with the 24-hour urine. If it's like, man, you have all these symptoms and your blood pressure is super high and you have protein, those are some examples of times when I wouldn't delay it for a 24-hour urine.
Okay. What about swelling? This is something we always hear about. People are always very concerned about swelling. Do I have preeclampsia? Swelling can be normal in pregnancy. It's just kind of part of pregnancy, but it could also be concerning. How do we discern between the two? And also, why is that not part of the diagnostic criteria?
Yeah, that's such a good question. Mainly because edema or swelling in the feet and the lower part of the legs is very common because we stand most of the day, right? And so you're going to get this dependent edema in areas you're not moving around as much, and gravity goes that way. You also, during pregnancy, your peripheral, so at your hands and your feet, vascular resistance is down, meaning the vessels aren't pushing the blood back up to the heart. So the arteries will take the blood down to the feet and the veins will bring it back up.
Got it.
So your veins don't have as much of that squeeze to them when people are pregnant. So you will notice your feet will swell more. You might have to wear a bigger size shoe. So that is normal for the feet and the legs to get a little bit swollen because of that decreased peripheral vascular resistance.
And does that have anything to do with that we're retaining more fluid in pregnancy and the increase in blood volume?
So a lot of that has to deal with that, and you get to osmolality. And so what happens with preeclampsia, the easiest way to say it is you get leaky vessels. So the leaky vessels you get aren't your big vessels, they're your small vessels. So places that you don't really think about having leaking, I guess you could say. So when people get edema or swelling during preeclampsia, it's oftentimes in places that you don't have typical edema when you don't have preeclampsia. Hands, face. So hands and face swelling is not on the big criteria, but it is still one of the physical exam findings that we need to think about. Feet and ankles and the lower part of the legs, if it's bilateral, it gets better during the day when you walk. That's not a criteria of preeclampsia. Hands and face, again, not on the objective criteria list, but a big red flag.
Totally.
And the way you can tell for a face is usually ask their partner.
Pregnancy nose.
But their nose. Because so my sister, and she's fine with me talking about this, we both have kind of like a box nose or a button nose. Her nose went like bulbar, round. And I was like, what did you do with my sister? So that's very, very different. And so when we ask and want to know why it all happens, so much research is going on to figure out what's the nidus, like what starts to make all of these things happen. But part of it is at the very small capillary level of inflammation. And then once that starts, we just get badness. So swelling is due to these leaky vessels and the osmolality and what's more salty, I like to say. And where goes salt, so goes water. So if you have this imbalance and you have leaky vessels, that intravascular stuff is going to go extravascular. Right. And it's funny, people think if they're swollen, I need to drink less water. That's not
opposite
the case. And so that's the thing that's really frustrating with preeclampsia like that. The other thing, I just get jazzed about this. I'm so sorry.
No, don't apologize.
When you mention the plasma volume, the volume definitely goes up during pregnancy. Your plasma volume does, which makes people what we call delusionally anemic. So let's say your hemoglobin is 14 and you become pregnant, and then your hemoglobin ends up looking like around 11. Could be normal delusional changes in pregnancy. Let's say you get preeclampsia and we do a CBC, a complete blood count, and your hemoglobin now looks to be about 9. Okay. I can almost guarantee you that your hemoglobin is really closer to 7 because you have this delusional anemia as well. And I'll tell you, people who have really bad preeclampsia, if your hemoglobin started at 14, you become pregnant, delusional anemia, you get down to say 11. If you get preeclampsia, your hemoglobin actually may increase. And so if you come back then and you're having headaches and things, and I'm like, wow, your hemoglobin was 11 and it went up in pregnancy.
Red flag.
And now we're at 12 or 13. People with preeclampsia, bad preeclampsia, they hemoconcentrate.
It's like a compensation from your body.
It's almost a compensation. So if you're not aware of these physiologic changes and you need a C-section, 2 things I need to be aware of. Number 1, your blood is going to be really thick. Okay.
Got it.
It's going to look almost sometimes gelatinous.
Wow.
And then after this baby delivers and your preeclampsia typically starts to get better after delivery, your hemoglobin is going to plummet. And if you know the preeclampsia causes a hemoconcentration, if you came in with a hemoglobin of 12, you're probably more like 10.
Wow.
And it's nice to know that before any big surgery or before delivery, because you could drop substantially.
And what is that going to feel like to the patient? Are they going to feel lightheaded, nausea, or maybe we don't know at all?
Maybe we don't know at all. No. And that's the part where that postpartum period is so
Critical.
scary, because you'll know then, because you're going to lose some blood during a delivery.
Sure.
And if you have this anemia that's being masked a little bit and you're losing that blood, you might not feel it or show vital sign changes until postpartum time.
Which is scary.
It is, because people deliver and then it's like sometimes postpartum is a very vulnerable place.
Sure.
Because everyone's paying attention to the baby.
Sure.
You know,
Postpartum is also a time where I feel, as a doula, sometimes the hospitals feel very like, okay, we made it. We made it on the other side. And I feel like a lot of times they just kind of do their routine checks. And if you as the patient don't know to look out for these things and you don't have an MFM that's following you, or maybe your MFM just isn't there and no one has read your notes, it can be a time where things fall through the cracks. And that is very, very scary.
absolutely. So many big changes happen after delivery, these shifts that are occurring in the body. And there was a study at one point that most maternal deaths are occurring within that 6-day postpartum period.
Yeah.
That's when most blood clots are going to happen,
Yeah.
like within your legs or your lungs. And that's a big vulnerable time for all patients.
Yeah, that's scary. Okay, so you had talked about post 20 weeks. I have 2 questions. A, why is 20 weeks important? And B, what happens to people who have high blood pressure presenting at 19 or less?
Yeah. Such a good question. So 20 weeks is kind of this place. If you were to look at how we classify pregnancies, we have this terminology where we say I'm a G1 P0.
Sure.
And that would mean I'm a Grada 1. So I'm pregnant right now, para 0. So I haven't had any babies. And we play with those numbers. And 20 weeks is when quickening is meant to occur, which is where individuals start to feel flutters or movements of the baby. Now, many people will feel it before, totally fine. But we like to know that you feel some type of something, a wiggle, a movement by about 20 weeks.
Okay.
So that's where that kind of definition comes. And when we look at classifying pregnancies in the G's and P's, we do term, preterm, A for abortion, and L for living. And between preterm and abortion, 20 weeks is where we would classify it as being an abortion, being like a spontaneous abortion, or what we call a miscarriage. And then the preterm would be anywhere from 20 weeks to 36 weeks and 6 days.
Sure.
So that's where 20 weeks is a magic number in our brains, kind of. And then, so anything that has the word gestational before it, gestational hypertension, gestational diabetes, gestational thrombocytopenia, means it got diagnosed after 20 weeks.
Oh.
Yes. Key time. And then, so if someone has hypertension or high blood pressures before 20 weeks, we would call them chronic hypertension, meaning that even if you didn't know you had hypertension before you got pregnant, you're having enough changes in the beginning that we would classify you as someone with quote unquote chronic hypertension.
Meaning that it's kind of present before you got pregnant, but we might not have seen the signs.
Correct. And you get treated differently in a good way, because if you can get that, I hate to say label, but for insurance purposes, if you have the diagnosis of chronic hypertension, you may need an EKG, the mom. You may need an echocardiogram because you could have had it for a while.
Sure.
You may need to have antenatal testing or fetal monitoring sooner. You'll need a growth ultrasound at some time because growth restriction is associated with chronic hypertension.
Okay.
And your delivery may need to happen earlier because your risk of preeclampsia is higher if you have chronic hypertension.
Got it.
So it changes recommendations and things like that.
So talk to us about how it changes recommendations in pregnancy. Let's say we get diagnosed with preeclampsia. Are we going for extra scans? Do we have risk of stillbirth? Do we have risk of a big or a small baby in our uterine growth restriction, placental complications, any of that?
All the stuff. So preeclampsia by itself, the answer is yes.
Okay.
And then if you climb up to preeclampsia with severe features, the answer is absolutely yes.
Double yes.
Yes. Because it doesn't necessarily go linearly, but you have preeclampsia, then you have some of those labs and symptoms I mentioned can bump you up to preeclampsia with severe features.
Okay.
We used to call it severe preeclampsia.
Okay.
And they changed it. Some people still call it that.
Sure.
Then you can actually have something called HELP syndrome.
Yeah.
And the acronym kind of goes along with elevated liver enzymes, low platelets, and the H is for hemolysis. You don't have to have all the letters to have it, by the way. So then they would call it atypical HELP. But if you got some of the labs, you fit that criteria. And then you get eclampsia, which is the seizure. So any of those have these risks. And the risks for patient would be they could have a seizure at some point. They actually have a higher risk of having heart issues, heart failure later down the road, not necessarily right now. Okay. Cardiovascular risk, hypertension later in life increases by about 50%, I want to say.
Wow, that's a lot.
Substantial. It may even be more than that. And for the fetus, we have growth restriction because think about it, if we have vessels that aren't working super well, they might be inflamed, things like that. That could be a problem. If they're leaky, that could be a problem. Stillbirth is also going to be a problem. So growth ultrasounds, yes. Second thing would be antenatal testing or some type of fetal monitoring, whether it's the belts that go around, which we call the non-stress test, or a biophysical profile, quick ultrasound. And then growth ultrasounds, I think I mentioned that already. For the patient themselves, blood pressure monitoring, usually at least once or twice a day.
At home by you.
Yeah. Yeah. Making sure your cuff works well if you can. And labs once a week. Because remember we said preeclampsia and then severe features. Sometimes you might feel the same, but your labs might change substantially. And if no one's watching those labs once a week, you don't want to miss getting severe features or even HELP syndrome, because then your risk of complications increases, particularly for stillbirth and for seizures for the patient.
I had no idea that HELP syndrome was associated with preeclampsia. Wow.
Yep. If you look at the severe features, they're very similar to HELP syndrome because H is hemolysis, just sometimes that was a harder one. I think it really fits criteria for us. And then EL is elevated liver enzymes and then LP is low platelets. And elevated liver enzymes and low platelets are part of the severe features of preeclampsia.
So for people who've been diagnosed with pre-E, they're going to their doctor every week, even though that may not be the traditional kind of standard routine schedule. Once you get pre-E, we need you in once a week.
Yeah, it ups you substantially because of those risks being there. And I think it's hard for people sometimes to accept the diagnosis of preeclampsia because what comes along with it is earlier delivery. And that can be, if you had a plan to get to your 40 weeks, preeclampsia, you're delivering at 37 weeks on the nose. Because your risk of progressing to things that can be worse for you and for baby and for the outcomes being worse is so high that we deliver 37 weeks.
So what about people who are staunchly against that and they say, not going to do it? Now, how does that conversation usually look?
I think it's for sure a conversation to have with a maternal-fetal medicine specialist if they have not done that already. I think it's reviewing your risks and trying to understand that, because if you're going to push past that, the risks are so high.
Yeah.
And if it's like, I'm not going to do it, then in my opinion, it would be, then we need to make sure that that fetal monitoring is happening 2 to 3 times a week.
Sure.
We need to be sure that those labs for you are definitely happening regularly.
Sure.
We need to be sure that you're watching your blood pressures. And if you hit certain levels, you have to go to the hospital immediately.
Yeah.
You can't be alone. I mean, I wouldn't have someone probably drive. What if they seized?
Wow.
I mean, there are things that can happen. And in fact, some data too shows that even if you don't have the severe features, you can still have a seizure. We used to really think that only the severe feature people would have the seizures. Man, it's not the case. It's not the case. And that's what's really frustrating too, because you can feel fine. Sometimes it's the blood pressures and the labs, and you're like, but I feel okay.
Crazy.
Yeah. And that's the hardest one to accept probably. And some of the symptoms can be this epigastric pain,
Okay.
which a lot of people have during pregnancy, right? Like I feel kind of nauseous, or like things are pushing. It's hard to eat a full meal. And a lot of times that's because the liver is pushing. And then those liver enzymes will be high.
Wow.
And I had a friend, she was 28 weeks working with me. We're delivering babies, doing our thing. She's like, and she's pregnant. It's like, oh my, I got some reflux going on today. And I was like, you checked your blood pressure? No, I'm fine. I'm like, have you checked your blood pressure?
You know better.
Doctors are their worst patients, right? So she checks her pressures. They were a little high. I'm like, you need to get labs. And she's like, I get it. I'm like, no, I'll cover your patients. Go get your labs. We got this. Her liver enzymes were through the roof and her platelets were, she had HeLP syndrome, full-blown HeLP syndrome.
Felt fine. Otherwise,
other than just this kind of mild, whatever, you know? So those are the things that, you know, if it doesn't feel right, because, you know, nausea and vomiting in the first trimester, pretty common.
Sure.
But when it goes away and then it comes back again,
could be a red flag.
That's a red flag for sure.
Okay.
For sure.
Yeah. Wow. Okay. So in terms of delivery, does it mean we have to have a C-section? Are we looking at an induction? What does that mean for delivery in terms of diagnosis?
So nothing about the diagnosis of preeclampsia in and of itself means a C-section.
Perfect.
So it just means delivery at 37 weeks. Now, if you get severe features, that's a whole nother story because
Okay.
that's earlier than 37 weeks.
Okay.
This is a side note. But say it's run-of-the-mill preeclampsia, 37 weeks. No, induction's fine.
Okay.
Induction's fine. And then it comes into, once an induction starts, all the typical things. Are you progressing? How high are your blood pressures? Are they under good control? Those types of things.
Yeah.
And those are just conversations to discuss with your provider, but nothing about the diagnosis of preeclampsia means that you need to have a C-section at all.
You know what I find bizarre are the people who have preeclampsia and they have the high blood pressures in pregnancy and then they get into labor and their blood pressure is perfect. I'm like, what are we doing here? Like, what the heck is happening? But it also gives me the assurance that I think your body needed this. Your body was asking for the help. And once we got the support and the help and got your baby kind of on the way, your body was like, okay, I can do this. Like, I don't have to, I'm not waving my white flag anymore saying like, help me.
And the other thing too, that may contribute to that some is oftentimes people receive magnesium sulfate when they have the diagnosis of preeclampsia because it's a smooth muscle relaxer.
Okay.
And it relaxes all your muscles, really. It can make you a little flush too, and you feel a little tired. And sometimes we'll notice that blood pressures, when people's bodies are more relaxed, that their blood pressures will go down some.
Sure.
Yeah. And that happens. And the other thing too, I'll make sure I mention that, is that we mentioned kind of gestational hypertension.
Sure.
Delivery for gestational hypertension is the same as preeclampsia. That's different. That changed when I was in fellowships. That was a while back. It used to be 38 weeks and now it's 37 weeks because if you let someone with gestational hypertension, which means blood pressure diagnosed after 20 weeks, but you don't have the protein, you don't have any of those symptoms,
no swelling,
and you don't have any of the labs. Now the symptom of swelling, remember,
could be
soft one, right? But you don't have the weird visual changes, headaches, right upper part pain, and all your preeclampsia labs are normal. You still have high blood pressure after 20 weeks. So we call that gestational high blood pressure, gestational hypertension. 37-week delivery. That one's a really hard one for someone to swallow sometimes because they're like, no, I just had the blood pressure because I was anxious or I was rushing today. But if you continue to check your pressures and they continue to be elevated and you get gestational hypertension, if you don't deliver at 37 weeks, your risk of getting preeclampsia, that is approximately 50% from the most recent data. And that's just like a disaster waiting to happen. That one's very hard for people, I think, because they usually feel they feel fine. And it's a difficult one to have, for sure.
Anytime that something throws you off of your birth plan or what you had expected, I think is really, really tough. It sucks.
Yeah. And you know what's interesting too? There is a wonderful, I call it a snippet or like a little template, a little thing I always talk about. If I'm ever recommending someone deliver early term, which is 37 weeks, early term, there are things to be discussed before that delivery happens. And I think that is missing sometimes. I think people get busy or we assume other people know things. And when we say 37 weeks, have a good day, there's so many questions that you don't know to ask right then. That if the provider doesn't prompt and say an early term delivery still has risks, which could include maybe a stay in the neonatal ICU,
Okay.
maybe lower APGARs. Those
Okay.
could happen. What are our benefits? We keep you hopefully from having a seizure or that it progresses that way. We hopefully protect any other bad things on your blood, like your liver enzymes going up, your kidneys not functioning well. And those things are important to keep your baby safe and hopefully decreasing the risk of stillbirth.
Sure.
So when we get that conversation out first, maybe a small NICU stay, maybe that's a small risk that's increased, but it's there versus a possible seizure and stillbirth. That's where the 37 weeks comes from.
Sure.
Because that's 3 weeks before your due date. But those last 3 weeks, if someone doesn't get induced, everyone's biting their nails and worried and it can be super, super stressful. And you don't want to get stressed, right? Because then your blood pressure can go up even more. Those kinds of things.
If you're in the thick of postpartum right now, like me, your bed becomes your command center. Cozy Earth's bamboo sheets are what dreams are made of. Literally. They're breathable, moisture wicking, and cool to the touch so that you can kiss those middle of the night hot flashes and sweats goodbye. Not only are these the softest sheets I've literally ever felt in my life, but they help you from overheating. They help you sleep several degrees cooler. They're perfect for snuggling on winter nights and waking refreshed for the mornings ahead. And I also love that you can try them completely risk-free with their 100-night trial, and they come with a 10-year warranty. These sheets make even a 30-minute nap feel like a luxury. It's like a deep sigh woven into the fabric. This isn't just bedding, it's postpartum self-preservation. Plus, they wash like a dream. There's no fading, there's no pilling, there's no shrinking, thank goodness. Just the same soft, cozy magic again and again and again. And if you're spending more time than ever in bed, feeding, bonding, crying, hey, no judgment, then your sheets better be working as hard as you are. You deserve luxury. You deserve to be wrapped in softness, stay cool throughout those hormonal roller coasters, and feel human again while caring for your newborn, even when you haven't showered for 3 days. Cozy Earth products are also sustainably made, temperature regulating, and built to last, which means this is the kind of gift that keeps on giving well past that newborn stage. So whether you're pregnant, postpartum, or gifting someone who is, grab 20% off using the code HeHe, HeHe, that's HeHe, for 20% off sheets, pajamas, loungewear, towels, washcloths, and so much more at CozyEarth.com. And don't forget to grab your Cozy Earth jogger set for running errands or those mini appointments that come your way in the first few weeks postpartum. You will feel put together while also feeling relaxed, because becoming a mom doesn't mean giving up style. It literally just means upgrading intentionally to be cozy, comfy, but stylish. So is there anything we can do to prevent preeclampsia? Watch our salt intake, increase your water, aspirin. There's all this talk about baby aspirin, starting it by 16 weeks. But if you didn't think you were going to have preeclampsia and you didn't start the aspirin, is it too late to start it? Yeah. What does all that look like?
Yeah. Aspirin is really the main thing.
Okay.
In all honesty, they had some studies on calcium. Those didn't really hold much water. So the big thing is aspirin, starting it at 12 to 16 weeks.
Sure.
By that time, 1 a day, 81 milligrams with food, always with food.
Okay.
Otherwise you can get a little nauseous. And the thing that's interesting too, is that when you look at people that should take it, if you have twins, just having twins is enough to need a baby aspirin.
Wow.
Being diabetic in and of itself is
pre-pregnancy.
Pre-pregnancy.
Sure.
Correct. Having hypertension.
Pre-pregnancy
is enough.
Wow.
Those are things that are enough by themselves. Other things that if you have two or more, you can say 2 or more or greater than 1, right?
Okay.
Risk factor. Your age is 35 or above.
Okay.
You are obese, BMI above 30.
Okay.
By definition. You had a sister with preeclampsia.
What about your mom?
Mom, first degree relative, yes, sister or mother. If you yourself had preeclampsia before, that in and of itself is enough to need to start aspirin. So there are tons of risks there. The one that people really forget about is if it's first delivery.
Okay.
Because people forget about that. Younger women, actually teenagers and older, have higher risks of preeclampsia.
Wow.
So ends of age, younger or older. And then the big one everyone forgets about is Black race. So Black women have such a higher risk of preeclampsia and hypertension overall. And they changed this recently because of the way in which racism is affecting our medical community. That regardless of anything else, if you were a Black female who was pregnant, you're at a high enough risk because of injustices and racism as a baseline that you're recommended to take aspirin.
So why is the recommendation not to put all first-time pregnant people on aspirin so that all first-time moms can just kind of have this almost safeguard?
They've been doing some studies here and there on it, and they're not the best studies. It's hard to get a great study. But I think the concern is if we blanket it, we're going to end up having a few side effects that we didn't know about.
Got it.
And I say didn't know about because maybe we didn't take a full history on the patient. Because if you've had an allergy to aspirin or products like aspirin in the past, you shouldn't take it. If you have blood disorders where your platelet count's really low, if you have gastric ulcers or some type of ulcer in the stomach or intestines, some types of liver disease. So that's a good question. We actually joke about it all the time. Like, just put it in the water. Right. And so I think that it seems very safe, which is great. And some countries are going up to 2 baby aspirin a day.
Really?
Yeah. And some places in the US, because as you know, I work in different states all the time, right? I've seen recently that some states are doing 162 milligrams a day. Now, that's not a supported recommendation by ACOG. And
As of now.
And so some European countries do it, and apparently some places in the US do it. For me, one of the big side effects of aspirin in general is bruising, just because it thins your blood just a little bit. Its main mechanism is decreasing inflammation. So that inflammation, we think that preeclampsia is really causing at these small vessels in the body. It's decreasing inflammation to small vessel levels. It's not going to decrease your blood pressure. So people get worried, like, I can't start it because I have low blood pressure. Blood pressure goes down in the first part of pregnancy. We're not going to give you anything to drop your blood pressure, but it does thin the blood a little. So if you're clumsy like I am, and I take aspirin, I end up with these little bruises sometimes.
Where does that come from?
And nosebleeds are more common during pregnancy. And so I always tell people, if you start it and you start having bruising, nosebleeds, anything like that, you can go to every other day. So those are some things you can do. And you asked too about if they're after 16 weeks, is there still benefit? There may be. So I still ask people if they get in a little later, I tell them you may not have as much of a benefit now, but if you really have the criteria to go ahead and take it. And then next pregnancy, start at about 12 to 16 weeks.
And what about salt intake? Does that impact preeclampsia at all?
So salt intake has a big effect on blood pressure in general, no matter what. So for sure. Now, is it going to cause you to get or prevent you from getting preeclampsia? Not necessarily. Will it make your blood pressures higher or lower as a general statement? For sure. Some people are more sensitive to salt than others. So some people can eat a whole bag of popcorn and it doesn't affect them. And then some people can eat like 2 pieces of popcorn.
You just smell the salt.
And I blew up. Stay Puft Marshmallow. But so when I recommend, and this is for everybody, 3,000 milligrams or less is really recommended. But I recommend 2,000 milligrams or less daily for people with hypertension. Correct. And there's no need for anyone ever to get that much salt. But I challenge you to look at any frozen meal and just turn it over, or any soup. Those two super high in sodium. Sodium's the same as salt. And the amount will just like blow your mind. And look at the number of servings. Because if it says like 800 milligrams, there may be 5 servings in that one thing of frozen whatever. Fascinating.
Yeah. I mean, I think that's a testament to the benefit of eating whole foods and to really try and pay attention to how much processed foods you're having in pregnancy, which obviously opens up a larger conversation about racism and access and lack of access and just the food quality in America. But when and where you can cut that processed food, it's always going to be better.
Yeah. Any of the processed foods are going to have more preservatives. And so then you're going to get, that's exposing you to more inflammation overall and way more salt. Way more salt.
Okay, so you had mentioned magnesium, usually in a drip form in pregnancy. What about taking magnesium in pregnancy? Is this a good idea? Could it be a protective factor in maybe not preventing, but mitigating preeclampsia at all?
I like magnesium for constipation and headaches. So will it help with those things? Yes, for sure. Smooth muscle relaxer works for that. As far as anything for preeclampsia, they have not shown that it's helpful to take magnesium. And I don't know if it's because of the dose in and of itself.
Yeah.
But what I actually think, if I were to kind of jump and make a hypothesis.
Sure. A little guess.
They're looking at certain things that are thought to be in the blood of certain people that have inflammatory processes, right?
Oh.
And so inflammation is really thought to be the key as to what makes it really start. And so magnesium really isn't going to change that. Now, it does relax muscles. So that magnesium can help as a smooth muscle relaxer,
Sure.
but really mechanistically is not going to be working at the level to prevent preeclampsia, but it can help decrease the concern for someone having seizures who's been diagnosed with preeclampsia.
Yeah.
So
it's also magnesium sulfite, you said.
Sulfate.
Sulfate.
Mhm.
There's a million magnesiums out there. And
so many.
you know, the chances that you're getting the right one in pregnancy, I think is pretty low, especially if you're not aware that there's so many magnesiums out there. You know, again, it comes back to access to quality and where you source in your magnesium from. Are you eating foods that are rich in magnesium?
Sure.
Do you even need supplementation? Yeah. Okay.
Yeah.
Wow. Preeclampsia is pretty complex.
Yeah, pretty complex. And we see so much lately about people getting preeclampsia that I would be willing to guess we're not counseled about the risks of it,
I think you're right.
And it's not like it's uncommon. I mean, worldwide, you get up to about 8% of people.
That's a lot.
Or 8% per pregnancy, right? So, I mean, the rate is high. Financially, there was a study in 2012 that said in the first 12 months after delivery, for caring for the patient and the infant, 12 months after, the total to the US, guess the number. This is from 2012, so it was about.
I couldn't even begin to guess the number.
$2.18 billion.
Just on resources in supporting people who have been diagnosed with pre-E and their babies.
Correct. That
Why?
shocks me.
What are we doing in those 12 months after? What's the money being spent on? What does that look like if you had pre-E and pregnancy? Now what does postpartum look like?
I just got chills. The risks that happen, like say there's a seizure.
Sure.
Right? That's a management issue right there. Number one. Number two, staying in the hospital after delivery is higher because of the complications that may have occurred, such as maybe a seizure. The other big thing is pulmonary edema or getting fluid on the lungs. And like we kind of talked about before, postpartum, it's like, okay, you're good, you delivered. And delivery is the treatment for preeclampsia. Because as we talked about inflammation, a lot of that inflammation may even start when the placenta starts to implant on that microscopic level. I like to show people my hands and say, if this is your uterus and this is the placenta, microscopically the placenta is invading. And then at that small microscopic level, that's where the vessels are kind of sharing. That's where this oxygen exchange is occurring. So if you don't have good implantation in the beginning, that can affect so many things down the road, which is where growth restriction comes in later.
Yeah.
You won't know right at implantation, but you'll know as you get further along. And we know this too, because people who have had preeclampsia and then they change partners, have a new partner that's fathering the next pregnancy, they may not have preeclampsia again. So they're linking this a lot even. So somebody put one time, like, could the father of my baby be causing preeclampsia? It's not technically him that caused it.
It's his fault. You did this to me.
There's data to support that. So if you want to change partners and because you've had preeclampsia 4 times, that could actually decrease your risk a little bit.
Wow.
Yeah. I got off on a tangent with that because we were talking about, what were we talking about before that part?
Oh, how $2.1 billion is spent on postpartum care.
The complications of it, the readmissions, postpartum preeclampsia is still a thing too. So that is going to be part of that as well. So people who, let's say, had high blood pressures, maybe they didn't get diagnosed with preeclampsia before delivery.
Okay.
They deliver, pressures are a little high, and it's like, oh, I was in pain. And it's like, okay. Then they go home and have a seizure or go home and have a headache and get readmitted. So postpartum preeclampsia is part of that too.
Okay.
And I think we forget that diagnosis is still there. And that readmission now is magnesium for seizure prevention as best we can and hypertensive management. And there's just too many stories. So a separate friend of mine, I was in the Bahamas, got a phone call postpartum. She's like, I can't really breathe well. Long and short, she'd had some blood pressure issues. I'm like, you need to get in there now.
Sure.
It sounded like she had pulmonary edema.
That just gave me full body chills.
I'm like, ask your doctors to make sure that they do a chest x-ray, see if they can get you something to diurese you, help you to pee off some of this extra fluid that sounds like it's on your lungs, also swollen everywhere.
Okay.
7 days in the hospital. The OBGYNs managing her didn't consult internal medicine until the 4th day of the admission. So she was given medication that didn't even help her, was not diuresed for 4 days until they noticed the oxygen saturation is dropping. And also, I think it was blamed on anxiety for the first 2 days. Do you know what I mean? And there's no words for that. And this is someone who's smart, very intelligent, attempting to advocate as best they can for themselves and kind of getting pushed aside. I mean, if you have blood pressure issues, you're postpartum, you can't breathe well, you can't lay flat, you have fluid on your lungs, or maybe even on your heart, or you have a cardiomyopathy.
Like something is wrong.
Yes, this isn't a sit and let's give you medicine and throw it and see what sticks for 4 days and then consult an internal medicine physician or someone else. Like, this is a jump on board. This is what, and this is in a nice area of the United States that people think things like that don't happen. So imagine being somewhere that didn't have a huge hospital. And that your resources are lower and lower. This person had all the resources and insurance, etc., and still had that kind of care. I mean, there are no words.
There's no words.
There are no words. There are MFMs at that hospital. They didn't consult anyone. I don't know if it was a pride thing. I don't know what it was. Is it pride? Is it lack of knowledge? What is it? And like, it doesn't make sense. So the 2 point whatever billion, I mean, that right there could have been taken care of in a day if they would have been supported by the appropriate person and things would have been different. So that's one case, right? So imagine all the others. And I think that is where we're getting, and again, I haven't read the details of that study, but just from professionally being in that world, that's where that's coming from.
Makes your skin crawl, doesn't it?
It does.
To see people almost be sloughed off when they're there, clearly presenting with a problem, trying to advocate for themselves and not being listened to. I mean, I could just cry right now.
Yeah. It's irritating.
It's horrible.
It doesn't make sense.
Yeah.
It doesn't make sense. So yeah, that's why this space is so important, because you got to keep asking, you got to keep trying, you got to, because I don't know, the doctors get the training. It's on the website. I'm looking at the computer. I'm like, I could Google it. Like, they could go into a database and be like, troubles breathing, had high blood pressure, right? Like, I mean, I don't know. And I know that people are busy. I understand that too, but I don't understand how people get looked over like that so frequently.
It's just a broken system. It's broken for our doctors. It's broken for our patients. Our protocols are broken. There's just a lot that's broken in our medicine right now. But that's why conversations like this are so helpful. So I do have a question about, I want to call it post-eclampsia, but postpartum, pre-eclampsia. Is that presenting in the same manner as preeclampsia in pregnancy? Are we still looking at high blood pressures, the headaches, the kind of visual stuff, maybe the breathing, the liver pain? It all looks kind of the same.
Same. The one thing I will say is it is sometimes harder to diagnose because a lot of people have pain after delivery, particularly if they had a C-section. So they may relate, I have a headache because I haven't slept. Epidural. That's another great reason. My baby's crying, so my head's pounding. I'm tired because I had a 20-hour labor. So a lot of the symptoms of preeclampsia can kind of maybe be delayed for a patient to tell their provider because they just feel like that's normal postpartum, maybe, right? Like, I might have a mild headache, I think that's part of why it's sometimes missed or misdiagnosed even, or if you call in and say, got a headache. Okay, well, it shouldn't just be take a Tylenol and call me in the morning. Let's check your blood pressure. Blood pressure cuff, let's go here, or come into the hospital. Let's check those things. And then asking, do you have any pain over in your right upper quadrant? How's your vision? How are your hands and face? Just to get a little bit of a feel, right? And the fluid shifting that happens postpartum is huge. So they might think, well, my swelling is normal. See, so a lot of those symptoms can just be looked over as normal postpartum.
Even by you as the patient,
Sure.
like even as patients,
Sure.
just kind of make, I don't want to say make excuses, but we can make ourselves feel like this may be normal or there are other reasons that this may be happening.
Yep. The other thing too, with the costs being so high, is that when people are sent home after preeclampsia, even people who had chronic hypertension and maybe didn't develop preeclampsia, but have known elevated blood pressures, when they go home, I think there's something missing with check your blood pressures at home.
Oh,
Come into the office earlier than 2 weeks out. Come in 4 days postpartum, right? Because when they go home, it doesn't mean that they don't need to be seen or checked in on for 2 weeks. They need to be seen more frequently. And that's also a part that is missing, is that really close postpartum follow-up. Check your blood pressures. Here's a list of things that preeclampsia can look like symptomatically. If you have these, call. If you can't reach anyone, go in immediately. Like that kind of stuff.
yeah.
That's a big thing too, that I think number one is missed, and number two contributes to the readmission rate for people with preeclampsia.
You would think that hospitals would have some sort of safeguard where if they had patients that had preeclampsia at 2 days postpartum, well, I guess you're still in the hospital 2 days postpartum, but 4 days postpartum, a nurse is calling to check in, or somebody is calling to check in to say, hey, how's it going, Lexi? I know you had a baby 4 days ago. We're just checking to see how you're doing. Oh, I'm doing good. Okay, I just want to make sure you don't have a headache, right? How's that swelling? I know that we saw you be discharged and you still had a little bit of swelling. Is that starting to go down? You don't have any pain in your abdomen, do you? That would, I think, fare well for everybody.
Yeah, I think so too. And that's the question of how every system is so different, right? And then it gets down to the big questions of whose job is that?
Yeah. Where does that money come from? I mean, don't get me started on that because the money is there. The money is there, but how do we reallocate the money to get that position, there in the hospital? Yeah, that's tough. Okay, I do have a question about checking your blood pressures.
Yeah.
So I know that there are criteria on the blood pressure checks. It shouldn't just be one blood pressure. You shouldn't have your legs crossed. We should probably give people a minute to, after they run up the stairs and they're huffing and puffing. Talk to us about the correct criteria of truly using our blood pressure checks as diagnostic material.
So a couple of things. You shouldn't have had just been running, talking, doing any big activity for a good, at least 5 to 10 minutes.
Okay.
Now, if you just run a marathon, you need more time. But if you walked up the stairs, it's hot outside in the middle of the summer, and you sit straight down and we take your blood pressure, that's not an accurate blood pressure.
Okay.
So relaxation prior to is important, number one. Number two, when it's seated, legs uncrossed, and your arm is meant to be right at the level of your heart.
Oh, okay.
So you shouldn't have your hand down or your hand up.
Wow.
So if they don't have a table in front of you, you'll sometimes notice they'll kind of put their arm underneath your elbow and hold it up.
I never see that. It's almost always just down by their side.
At heart level.
Wow.
The other thing is no tobacco or caffeine 30 minutes before. So if it's been within that, that's not technically an accurate blood pressure either. And the final big thing is the size of the cuff. And those things, I always would need to just look at the cuff and get multiple sizes. But if your provider only has one size of blood pressure cuff, and it doesn't fit your arm, you could be getting incorrect readings.
Sure.
So those are the big things with blood pressure.
And is there anything about having a couple of different blood pressure readings, like a certain amount of time apart?
So when you're looking at making big diagnoses, right, or changing clinical management based on that, particularly for preeclampsia, the definition states they need to be 2 blood pressures 4 hours apart, at least 4 hours apart.
Sure.
To give you the definition of preeclampsia.
Okay.
However, if that first blood pressure is a severe range, greater than or equal to 160 for the top number, greater than or equal to 110 for the bottom number, then if you repeat it again in 2 minutes and it's still elevated, that can still get you the diagnosis of preeclampsia.
That's a little confusing to me. How did we go from 4 hours to 2 minutes?
Because the severe range, when you get to the top number greater than or equal to 160, bottom number greater than or equal to 110, the risk of maternal stroke increases substantially for you having some type of a stroke, right?
Sure.
And
you wouldn't want to wait 4 hours.
No, correct. And those blood pressures need to be treated immediately.
Got it.
So that just jumps you into like, you skip the line at Disneyland.
Mhm.
Like you're up at
Fast
the front.
pass.
That's right. So like, if it's that level, that's like, wow, something's going on.
Sure.
And if you're checking it again, you can switch to the other arm, you know, those kinds of things. But what we don't like to do is try to make the patient's blood pressure better by
Sure.
changing something that we're doing, unless
Sure.
you're like, oh my gosh, I used the wrong cuff or something that's clearly obvious, you know. But anyway, so yeah, those criteria can change depending on the blood pressures. And it's really funny too, if you're not pregnant, blood pressure kind of categories are changing.
Oh, okay.
And so we use still hypertension as greater than or equal to 140 for the top number,
Okay.
greater than or equal to 90 for the bottom number. And that's a general statement. When you're non-pregnant, even before that, if you're in top number 130s, bottom number 80s, that's considered a type of hypertension and may actually get treated now.
Wow.
Yeah.
Okay, so tell us what those numbers actually mean. What is that top number versus that bottom number actually? What does it tell us about our body?
Yeah. So the top number we call systole and the bottom number we call diastole. And the best way I can kind of describe it is systole is when your heart is squeezing.
Okay.
Diastole is when your heart is relaxed.
Okay.
As a general statement. So when you have that blood pressure cuff on, and if it's a manual one where they pump it up and you can feel it getting tight,
Yeah.
tight, and then they start to release it, you can feel when your heart starts to pump. Boom,
Oh.
boom. You can feel it in your
Sure.
right. Remember like
Yeah.
when you have it done. So think about that. Okay. Pumping is systole, squeeze, my heart squeeze. When it starts that squeeze after they have cut off the circulation kind of, sort of, that's systole. And then you feel that pump, pump, pump. And then all of a sudden you don't feel it anymore. You don't feel it pulsating in your arm anymore. And it all relaxes. That's diastole. That's the
Wow.
diastolic phase in a way you can think of
Okay.
it. So that's the bottom number. So when someone manually takes your blood pressure, you can look at the little numbers that are kind of moving.
Sure.
And you can see they started it when my heart started, the pounding, the systolic boom, boom, boom. And then the bottom number was when it all finally relaxed, the diastolic phase.
Wow.
So yeah, that's what it is.
So we're looking at basically the difference between those two numbers. We want them to be so close together, not too close together, but not too far apart.
So yeah, so they actually we can look at the numbers by themselves because that is pretty standard and simple, I would say.
Okay.
Then you can take those two numbers and take the first one or the top one and then subtract the bottom one, the second one. That gives you a pulse pressure.
Okay.
Or if you're like really sick and in the ICU, they'll do something called a mean arterial pressure. There's a little more math involved, not a lot. And they base stuff on that. But the pulse pressure actually helps us a lot because it can help to decide what type of blood pressure medicine to use for patients.
Wow.
Mm-hmm. Yeah.
Wow.
Fun.
Yeah, that's fascinating. Oh my gosh.
I know, right?
Okay, so is there anything that we haven't covered in terms of preeclampsia that people should know either before their diagnosis, after their diagnosis, how it might impact your labor or your postpartum?
I think the biggest thing is you may need blood pressure medicine during your labor. You may need it when you go home, but you may not have to stay on it forever.
Okay.
So thing number one, you may need blood pressure medicine for a little bit or a longer period of time. Thing number two, every pregnancy now is at an increased risk of preeclampsia. And then I'd probably say another big one, thing number three, is that if you've ever had preeclampsia, tell people in your family so that your sisters or your children, right, can be aware because their risk increases and that you yourself from having preeclampsia have a lifelong increased risk of cardiovascular disease and high blood pressure. And that's just super important, I think.
Yeah.
And really the more severe and the earlier your preeclampsia happened in your pregnancy, the higher those risks are for you.
Wow.
As well as if you had it in 4 prior pregnancies versus just 1, then your risk is even higher. So those numbers are not linear, but they increase with the earlier diagnosis, the more severe the diagnosis, and the more frequent that you may have had it in prior pregnancies.
They just compound on one another.
Big time.
Wow, that is fascinating and also scary. I know pre-E is so scary, but I also feel a lot of comfort knowing that A, we know so much about it. B, we do have solutions and a lot of diagnostic criteria, and we have the medications, and we know what to do with preeclampsia. We know what to look for. I think it really comes down to patients knowing what to look for, being comfortable telling telling their doctors about it, and then their doctor's listening, unfortunately.
Absolutely. And just, when the pregnancy's gone, it's still your story that you had preeclampsia, and make sure your primary care doctor knows.
Yeah.
So when you're down the road and you're 60 years old, you're at a higher risk of cardiovascular disease. And if they're like, I don't care about your obstetrical history, you should.
Yeah. I need a new doctor if you don't.
Yeah. But yeah, I'm glad we talked about aspirin too. I just think that it shouldn't be a hidden secret. Like it's there. And as physicians and providers in general for pregnant individuals, we've got to increase the education as much as we can.
Yeah, absolutely. Okay. So this podcast is all about advocacy. And, that's my whole MO in life, is just helping people advocate for the care that they need. If someone calls their provider, either in pregnancy or postpartum, and they say, I'm a little worried about preeclampsia, I'm having these signs, I know that these are not normal, or even it may be anxiety, but I'm worried it's not normal, and their doctor maybe doesn't listen to them, what would you say as a doctor that you would want to hear from your patient that would make you take them serious in terms of like, okay, I'm going to bring this patient in?
Well, I think I first would say if they're not listening, you go to a triage area to a hospital and get evaluated.
Okay, just go.
Yeah.
You don't need permission to go.
Yeah. If a doctor wasn't listening or provider wasn't listening, I would say to them, I'm going to go get evaluated, and here's where I'm going, and let them know where you're going. Take any records you have with you.
Yeah.
But as a provider myself, as a physician myself, what would I want a patient to say to me? First off, I would never, ever, ever.
I know you wouldn't. I know you wouldn't. Would you want to hear them say like, I'm scared? I am scared. Would it help you to hear like, I don't feel heard. I don't feel like you're listening to me, and I'm very scared for my safety and my baby's safety?
That'll do it for sure.
For sure.
I mean, that'll definitely do it. The reason I think this resonates so much is I've heard the stories of people calling in and they're ignored, and then they come in with stillbirth
or had a seizure.
And I feel like most of the times they spoke with someone that wasn't a provider, but that was at a hospital. Maybe, I don't know who, but someone that maybe clinically just didn't have that in there. So I would also ask, can I speak to someone else? So maybe that's the thing that could get a provider that's not listening to pay better attention or listen harder, maybe, is if someone could say, I don't know if you're really hearing or addressing my needs. Is there someone else that I can speak with? Or not even is there? Who is the next person up that I can speak with, because I'm concerned and I need to talk to them?
Yeah.
I think that may be a helpful statement overall to kind of have in our pocket a little bit.
That's really great advice. Okay, you mentioned a freebie. Tell us about your download for preeclampsia, and then also where people can find you, how they can work with you. If people wanted to work with you one-to-one, how do they do that?
Yeah, everything's on the website, drlexihill.com. Pretty simple. But for aspirin, they're, again, preeclampsia.org, my jam. I love that spot. They have wonderful videos and things, but I do have a really simple download to just kind of go through to see if you meet criteria for aspirin. It also has questions word for word that you can ask your provider.
Nice.
Am I a candidate for aspirin? Do I have any risk factors, or do I have any contraindications? Is there anything that says I can't take aspirin? Like maybe they have something in the records you forgot about. So it's an advocacy sheet to see if you're a candidate to take aspirin, and it's at drlexihill.com/aspirin.
Cool. We'll link that for you guys.
And then the other form is drlexihill.com/advocate. And it's just 13 questions to ask your provider. And it kind of goes through when during the pregnancy to ask it.
Nice.
They're base questions for everybody. Obviously, everybody's going to build on top of it, but it's nice to not forget some of those basic things along the way.
Sure.
And through the website, you can find modules that are educational. You can use the code pregnancy, all in caps, for any of my modules that are high-risk modules. There's hypothyroidism, there's advanced maternal age, there's hypertension.
Love it.
It's not on preeclampsia, but it is on, chronic hypertension. And people can also find me to book consults. And I do have a license now in Massachusetts.
Now? And you have a podcast.
I have a podcast too. And that's, you can go on the website and find all the links for it. It's on YouTube. It's on Spotify. Everything's Dr. Lexi Hill. That's it. Everything's on that. Instagram's the same for that as well. All the good stuff. And if there's ever anything else that you want me to do, just let me know and I'll do one. There's one on aspirin, actually. There's YouTube on aspirin. And it's just such an easy little, it's like a Tic Tac. So small.
You are such an amazing resource. I am so grateful that we got connected, and I just feel so synergistic when I'm with you. And I feel like,
I do firmly believe that all doctors got into medicine to make a difference, but I think sometimes, whether it be the system or it just, just life, some people lose sight, and you have not lost sight. You are still very much advocating for your patients. You are here helping people understand how to navigate the system that we have in the US, because it is broken. And it is really important that people have voices out there that listen to them and make them feel heard and are going to help them get the care. So thank you for being here. Yes. Thank you for being that voice for our people out there, for our preggies out there and their babies. And thank you to everybody joining us this week on the podcast. As always, connect with me on Instagram, Tranquility by HeHe, or the.birth.lounge. You can also find this show on YouTube. And if you're interested in having an informed and confident pregnancy and you want to learn how to respectfully communicate your goals and your preferences with your provider, join the Birth Lounge at thebirthlounge.com. All right, you guys, I will see you next week. Bye.
Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.